Thank you very much for the invitation to talk to you about strategies in neonatal care for growth and development. I don't have any disclosures relevant to this talk to make. What I'd like to talk about today is the link between nutrition, growth, and neurodevelopmental outcomes in very small preterm babies. And then just to provide you with some preliminary data from a recent randomized controlled trial we've been undertaking, which is aiming to understand how nutrition affects neurodevelopmental outcome. If we think about the nutrients needed for normal brain development, they are of course many, including the macronutrients such as protein, energy, and fat, but also many micronutrients and vitamins, shown here: zinc, thiamine, particularly iron and copper, and of course, energy. So if we think about the association between nutrition and neurodevelopmental outcome, we often use growth as a proxy for how good our nutrition is, thinking that good growth will then lead to good neurodevelopmental outcome. And indeed, there are many observational studies in the neonatal literature showing that good growth is associated with good neurodevelopmental outcome. So nutrition could affect growth directly, measured as weight, which is how most neonatal units assess growth, as shown at the top here, and then good growth could lead to neurodevelopmental outcome. Or nutrition could really just be important for brain growth and development, and this is commonly measured by the proxy of head circumference. And then this could be what leads to good neurodevelopmental outcome. Or of course, nutrition could lead directly to neurodevelopmental outcome without growth being important at all. We do know that nutrition in these extremely preterm babies is quite challenging. This graph from one of Chris van den Ecker's papers a few years ago now shows the association between amino acid intake in very preterm babies and nitrogen balance, showing really that an amino acid intake of at least 1 gram per kilo per day is needed just to maintain a zero nitrogen balance. And once muscle turnover is taken into account, this rises to at least 1.5 grams per kilo per day. And therefore, if we want growth on top of that, we can see that we're going to need even more, 2.5 or more grams per kilo per day of amino acids. Of course, what actually happens when these extremely preterm babies are born is that there's a rapid drop-off in their protein intake. In utero, it's somewhere between 4 and 5 grams per kilo per day. At the upper end here, if you take into account the protein that babies can get from swallowed amniotic fluid. But when the cord is cut, of course, this drops precipitously. And even with very careful attention to nutrition intake, we're lucky if we manage to get 2 grams per kilo per day into babies on the first few days after birth. So what evidence is there that the level of nutritional intake, particularly protein intake, which is what I'm going to focus on today, is important for growth first of all, and then neurodevelopment, which is of course what we're really interested in? Well, there is a Cochrane review, of course. This is from 2018 by David Osborne and colleagues, which has a whole host of different measures in there, which you can see in the Cochrane review online. I've just selected a few here, and this one shows you the effect of a higher versus a lower parenteral amino acid intake on weight at discharge. Now I'm showing weight here rather than some of the other measures for weight that we could use, such as Z-score at discharge, Z-score at 36 weeks, Z-score change from birth or another time point until discharge. And the reason I've chosen weight is because this is obviously a very easy measure, and therefore it's available for most of the studies, whereas some of those other data are only available for a very small number of studies. We can see here that in total, there are about 800 babies in these randomized controlled trials, and there is a beneficial effect on weight of a higher amino acid intake, but it's not very substantial, perhaps about 80 grams. But weight, of course, can be anything. It can be fluid, it can be fat, or it can be lean mass. And therefore, it's difficult to interpret exactly what this means. So how about if we look at head circumference? Again, this is actual head circumference rather than Z-scores. And if we look at head circumference, we can see that in this meta-analysis, there is no effect of higher parenteral amino acid intake versus lower on head growth at discharge, head circumference at discharge. And of course, if we look at the really important outcome, which is neurodevelopmental outcome, there are only 2 trials with a total of 200 babies showing no effect of a higher amino acid intake on neurodevelopmental outcome. Now, there are some other studies that have also assessed neurodevelopmental outcome, but this wasn't the primary outcome of the trial. And many of them are follow-up cohorts, and they show basically, most of all, no association between the nutritional intake, the protein intake, and neurodevelopmental outcome. There are some that show an inverse relationship, particularly the very small trial of Blanco et al., but mostly there is no effect. Now, in the Cochrane review, almost all of the evidence cited is graded as being of low or very low quality. And this, of course, means that we really do not have the evidence at present to tell us whether a higher amino acid intake is beneficial for growth and neurodevelopmental outcome in extremely low birth weight babies. The other question that's become very topical recently is whether early versus late parenteral nutrition in neonates in intensive care is of benefit or of harm. Again, there is a Cochrane review, but it's quite old now, from 2013, and again has a very small number of babies, fewer than 150 in total. This Cochrane review does show that early parenteral nutrition leads to fewer days to regain birth weight, but an increased blood urea nitrogen for what that's worth, and also less hypoglycemia, but hardly very robust evidence. And of course, the PEPPERNIC trial in pediatric intensive care, along with some trials in adult intensive care, have raised concern about providing early parenteral nutrition to people in intensive care. In the PEPPERNIC study, there were 209 babies, and these were mostly term babies, and 145 of them were less than 1 week of age when enrolled in the trial. And this trial, of course, compared late versus early parenteral nutrition. And in these babies, the likelihood of earlier live discharge was greater in those who received their parenteral nutrition late. However, overall mortality was not different, neurodisability was not different at 2 or 4 years. Nevertheless, there were some sub-analyses, particularly externalizing behavior and internalizing behavior, that suggested that late parenteral nutrition may be of benefit. So this dearth of available evidence and the low quality of the evidence that is available has led us to undertake the PROVIDE trial here in New Zealand with a couple of Australian units. And here is the PICO statement for this trial, which is that in extremely preterm babies who have an umbilical artery catheter in situ, does an extra 1 gram per day of intravenous protein for the first 5 days after birth, compared with saline, improve survival free from neurodisability at 2 years of age. So the primary outcome is neurodisability, survival free from neurodisability. And the reason we're using an umbilical artery catheter is that's the route for the extra 1 gram per day of intravenous protein. And we've done this because most of the RCTs in preterm babies struggled to separate out the two groups when just using the intravenous route. And so the planned difference is often not matched by the actual difference. Here's the consort diagram for the PROVIDE trial. We assessed nearly 1,000 babies. 482 were excluded, 240 because they didn't meet the eligibility criteria, 88 declined, and 150 were missed, meaning that we randomized 500 babies. Now, we had deferred consent for up to 24 hours approval by the ethics committee. And following that deferred consent, 40 families declined to participate. We were unable to consent 10 within the required 24 hours, and 6 died before consent was obtained, 5 randomized in error, leaving a total number recruited of 434, and the planned sample size was 430. You can see that we finished recruiting in October 2018, and in fact, we have just assessed the last baby at 2 years corrected age this month. And so we're hoping that the primary outcome of survival free from neurodisability will be available later this year. In the meantime, we have undertaken some secondary cohort analyses, particularly interested in exploring the associations between the nutritional intakes and growth outcomes, and also to investigate how nutrition in preterm babies affects refeeding syndrome. And that's what I'm going to turn my attention to now. So the first thing I want to point out about this cohort is that baseline nutritional intakes were not mandated. And that's because there is no real agreement on what baseline nutritional intakes would be. And that means that the participants received a wide range of nutrient intakes due to the differences in nutrition policies. Babies were recruited from all 6 level 3 neonatal intensive care units in New Zealand and 2 in Australia, so making 8 sites in total. So we've undertaken a cohort analysis investigating the relationships between macronutrient intakes and growth. And we did this by recording all actual intakes for the first 4 weeks after birth. And you can see how we've recorded those, but this was very carefully done to make sure we had precise nutritional intakes. Now, of course, if we're going to assess this with growth, a key question is, well, what is normal growth in extremely preterm babies? And I think the answer to that is that we don't really know. Of course, for a long time, the recommendation has been that postnatal growth and body composition of preterm babies should be equivalent to that of normally growing healthy human fetuses of the same gestational age, which would mean that as we monitored the Z-score change, for example, this would be 0 between birth and whatever point of time we are measuring. We now realize that that really is not an appropriate measure, and that after birth, all babies, and including preterm babies, will have postnatal weight loss due to the change in extracellular fluid component of body composition, and there'll also be regression to genetically determined growth. And most people now, I think, will accept that a Z-score change of up to -0.8 can reflect this normal postnatal adaptation. Given that there may be some regression to a mean, we can think that maybe acceptable growth would be somewhere between -0.8 and 0.8. And so for our analyses, that's what we've taken. And we've suggested that we shouldn't just be focusing on weight, because as I've mentioned, weight really is not growth. Weight is just mass, which can represent a whole host of things such as fluid and fat. That if we really want to assess growth, we also need to assess length and head circumference. Length, of course, being linear growth, which most pediatricians and endocrinologists would regard as being true growth, and head circumference, which is a proxy for brain growth. And so we suggested that target growth should be a Z-score change between -0.8 and 0.8 for all 3 of these parameters. So for the analyses we've undertaken here, we started with the 434 recruits to the PROVIDE trial, and then a number of babies died between birth and 36 weeks corrected age, as would be expected for these extremely preterm babies, leaving us with 363 babies at 36 weeks corrected age, or 84% of the initial cohort. These are small babies, median weight of 770 grams, median gestation of 25.7 weeks, 11% small for gestational age using the Fenton growth chart. But you can see if we're looking at the birth Z-scores that these are pretty close to 0. And of course, that's a reflection of the way that we assess growth at birth in preterm babies. And what we do is we plot their growth on population growth charts that are derived from babies born preterm. And therefore, it's not surprising, as shown on the left here, that when we plot babies of a large cohort such as this, they're distributed fairly symmetrically on that preterm population growth chart. But if we were to plot the same babies on an estimated fetal weight chart of fetuses who are remaining in utero of the same gestational age and who go on to deliver at term, we can see that there's really quite a marked shift to the left, as shown in this graph on the right here. And this really is indicating to us that as a population, preterm babies are growth restricted. And indeed, there are some fairly good studies indicating that growth of a fetus is linked to gestational length, even growth in the first couple of weeks of pregnancy. So what does the nutritional intake of these babies look like? This slide shows you the pattern of growth in the pattern of nutritional intake in the 8 different hospitals that took place in this trial. Across the bottom there, you have the measurements at 4 different weeks with the mean intakes across those weeks. And on the y-axis, we have the protein intake in grams per kilo per day. The blue shading shows you the intravenous protein intake, and the grey shading shows you the enteral intake. You can see that in these 8 hospitals in New Zealand and Australia, there is marked variation in the pattern. So if we look, for example, at sites 1 and 3, there is relatively low protein intake, below 3 grams per kilo per day, and this tails off quite slowly as enteral nutrition is slowly increased. And again, the final protein intake on full enteral nutrition or near full enteral nutrition is fairly low, below 3 grams per kilo per day. In contrast, if we look at sites 5 or site 7, we can see that the initial intravenous protein intake is substantially higher, 3 grams per kilo per day or above, averaged over week 1, and that this falls off fairly precipitously as enteral nutrition rises rapidly, so that by the end, we are achieving 4 grams per kilo per day of protein. How does this relate to the growth of these babies? Well, not surprisingly, growth varies quite substantially. And here we're showing the Z-score change now between birth and 36 weeks corrected age. And of course, as I alluded to earlier, if there was no change, babies would be sitting along here. And we can see that almost in all hospitals, there is substantial drop-off for all 3 parameters. However, for most hospitals, weight does fall within the expected growth rate of up to minus 0.8 standard deviations, but not for all hospitals, and particularly Hospital 1, which I pointed out as having a low protein intake, has very poor growth. If we look at length and head circumference, we can see that almost all babies have poor length growth, and quite a few of them, again, particularly Hospital 1, have a poor head circumference growth. So here, indeed, nutritional intake is associated with growth, particularly head circumference growth. What about the effect on other parameters? I mentioned that we can think of preterm babies as being growth restricted, and that's largely due to them being malnourished in utero. In the developed world, most of that malnutrition is due to placental pathology. Globally, it's due to either maternal undernutrition or due to malaria. So if we're providing nutrition to malnourished people, there's well-described refeeding syndrome, whereas the sudden provision of nutrition leads to an increased phosphate use for energy production in the cells. This leads to depletion in blood phosphate concentrations, which stimulates parathyroid hormone, acts on the bone to release phosphate, and when phosphate is released from the bone, calcium also is released, and therefore calcium goes up in the blood and phosphate is low. So the classic appearance of refeeding syndrome is a low serum phosphate, potassium and magnesium, and a high serum calcium, glucose and sodium. And this has a variety of effects on health, as shown in this diagram. So what was the pattern of particularly phosphate and calcium, which are the 2 minerals that we measured in the PROVIDE trial? Well, we can see a significant drop-off in phosphate over the first week after birth and a significant rise in calcium. And we defined refeeding syndrome for the purpose of this study as a phosphate of below 1.4 millimoles per litre and a calcium of above 2.8. That occurred in 61% and 23% of babies respectively, with refeeding syndrome, the combination of both, occurring in 20%. Interestingly, there was a marked effect of small for gestational age, with 22% of babies with refeeding syndrome having SGA, whereas only 8% of babies without refeeding syndrome were small for gestational age. Refeeding syndrome was significantly associated with adverse outcome in these babies. For example, death before NICU discharge occurred in 11% of babies without refeeding syndrome, but in 32% of babies with refeeding syndrome. Grade 3 to 4 IVH was doubled in those with refeeding syndrome compared with those without, though that wasn't statistically significant. And you can see that there was no difference in NEC or grade 3 to 4 ROP. Sepsis also was increased by about 50%, relative increase of 50% with a p-value of 0.06. As I showed you for growth, there is marked variation by hospitals. So here we can see that the incidence of refeeding syndrome in the 6 New Zealand hospitals varies from 7% to 44%. The proportion of babies who died before discharge varies from 7% to 27%. And the proportion of babies who died before discharge who also had refeeding syndrome varies from 0% to 77%, showing that the nutrition that we're providing has marked effects on these babies. So just to conclude, in extremely low birth weight babies, nutrition and growth are highly variable, even within a small country like New Zealand with relatively consistent approaches. And we still need good, high quality evidence on the optimal nutritional strategies to support neurodevelopment. And we also really need to know whether growth in NICU is a proxy for neurodevelopmental outcome or not. Preterm babies as a population are growth restricted and they are increased risk of refeeding syndrome. And we really need to be aware of this so that we can address it when it occurs. I'd just like to thank the Provide Study Group, particularly Dr. Barbara Cormack, who undertook her PhD on this with me and has been a long-term collaborator of mine, and also the whole Provide team. And I'd like to thank you very much for your attention and look forward to any questions. Thank you.